Why does it take a year for the nose to heal?
I didn't set the rules. I mean,
I thought you did.
I didn't set the rules. 1 in 10 patients that we operate on, at the end of the year, we may have to go back and do some additional refinement.
And what happens if they sneeze?
It's almost like the speed, I think, of a hurricane is the speed of the air going through the nose when you sneeze. There's your anatomy, there's your surgeon, and then there's whether you believe in God is the third component. Hi guys, Dr. Solomon here. I want to welcome you back to another episode of our podcast, Unfiltered. Today we're going to talk to you a little bit more about rhinoplasty, and I'm going to be fielding some questions that have been sent in about common questions relating to rhinoplasty. So take it away.
All right. So today we're going to talk about rhinoplasty, also known as a nose job. And it's considered one of the most complex surgeries. And maybe you can start off by explaining why that is.
Rhinoplasty is sort of a unique operation. It's sort of a special art form. It's different than many other surgical techniques that we offer in plastic surgery. The anatomy is unique. The nose has both function and form, meaning that it's an organ that's part of our respiratory system. So you're thinking always when you're doing surgery of maintaining a proper airway. It's got an internal component to it known as the nasal airway, which has different structures from the septum, which is a structure that separates, it's a wall that holds up the nose, but also separates it into two chambers. And then the side walls of the nose are called turbinates, and those are almost like the air conditioning system of the nasal cavity, which provides moisture to the air that's being breathed in, and it heats it up, and it also provides a bit of filtering. And then the external nose is made up of different lots of structures from what's known as the lower lateral cartilages, which makes up the nasal tip complex, which is sort of the softer cartilages. The top of the nose, which is known as the nasal dorsum, and then it interdigitates at the upper part of the nose into the nasal bones and on the sides into the cheekbones, known as the nasal bone and the maxilla. So all of those structures sort of make up the nose and have to be considered when performing a rhinoplasty. Furthermore, cartilage, which as we talked about makes up a lot of the nasal structure, is not always easy to operate on. It's easy to cut, but we're also in many cases reshaping, and it's not always totally predictable how you can reshape it. And some people have weak cartilages, some people have soft cartilages, some people have previously traumatized cartilages or traumatized nasal bone, which potentially can affect the surgical outcome. So that's what all those, and lastly, I didn't mention is the skin. So the nose is then covered by skin. So there's, in simplest terms, thin skin, medium skin, thick skin, and each of these provides different considerations to the surgeon. So for instance, someone with really thick skin often may be paired up with weak cartilages, such as an African-American patient. I mean, I'm generalizing, but there are some ethnic differences, may have thick skin, weak cartilages. Similarly, an Asian patient may have similar types of anatomy, in which case we have to structurally add to the nose to reshape it. Whereas a Caucasian patient who's looking for reductive rhinoplasty may have strong cartilages and thin skin, but then everything can show through the thinner the skin. You have to be very, very careful that everything's as perfect as possible. And then lastly, this thing's known as memory of the cartilage. I tell people it's like a tree branch in nature that's got a bend. And no matter how good the carpenter is, there may be these mechanical forces at play that are trying to rewarp or bend. So sometimes we do the surgery on noses that have intrinsic curves to them that may even be brought out worse from the rhinoplasty. So we sometimes see people that develop some structural changes with their nose over time as they go through the healing process. I just saw a gentleman now who I operated on over a decade ago, and he loved his result, but it started to bend a little bit over the last decade. Likely had some trauma at some point, maybe even early on in life. And now we have to go back and do some additional work to sort of hopefully rectify it once and for all. So those are, I don't know if that puts it into context for you.
Yeah, it's helpful because so many people come to you and they just want to get a nose job. And they think when they come to you for the nose job, it's going to be perfect the way they want it when it's done. And they don't understand the complexity that's involved. Part is your anatomy, part of it's the surgeon's work that he does. And part of another variable is just how your body responds to surgery. And it can shift and move and things can happen just as part of the healing process. So that's why we thought today we would do frequently asked questions, because we get lots of them. That's why they're called frequent. And we're just going to go through the list of all the questions that I've got here, some that are on the website, some that we get phone calls, patients afterwards asking questions. So let's dive right in, okay? So why does it take a year for the nose to heal. Like, that's a long time. Not everyone has the patience. I can tell you that. Not everyone has the patience to wait for their nose to heal after a nose job. Why a year?
I didn't set the rules. I mean,
I thought you did.
I didn't set the rules, but
thought you did.
Our entire body, when you undergo any kind of trauma, and surgery is trauma, there's going to be a healing process. So for instance, when you're talking about even a cut, it's going to go through multiple phases of healing. Part of the initial phase of healing is the inflammatory phase, where your body's like, hey, someone traumatized me, and it's going to send all these inflammatory cells in to fight infection. So similarly, that happens in the nose, and that creates a bit of inflammation and some swelling. It's part of your body's response to trauma. And then you're going to, that's going to start settling down, and then you're going to get some collagen deposition phase, whether it's a cut on your hand or a nose job. And the collagen is going to then come in, and it's going to add some structure and strength to the tissue that's been violated or traumatized with the surgery. And then one of the last phases, which takes months and months, is sort of a remodeling phase, where some of the tissue is sort of remodeling and settling. And, as I mentioned before, there's different parts of the nose, from skin, cartilage, and bone, and each of these is sort of going through their own unique independent sort of healing process, all having slightly different time frames, and it varies amongst patients. So we tell most patients they'll look pretty good aesthetically. I mean, what I'm talking about is sort of science and what's going on under the skin. In a clinical setting, the patients will look pretty good even in a couple weeks.
That was my next question. You just stole it.
Yeah.
When can people see the bulk of the changes? We usually say 6 to 8 weeks.
Yeah, within about 4 to 6 weeks, I think most patients look sort of 80% done. Some people look really close to their final result, but the nose will continue to change. Some people say a year. Some people find that with their photo documentation of patients in the recovery phase, they may take photos every year. And we have patients come in and say their nose changed after 1 year, up to 2 to 3 years, sometimes even as long as 5 years, that there'll be some subtle changes, usually with how much definition and refinement you get on the nasal tip. Mm-hmm. So those are all things to sort of just to keep in mind for patients. I wish that we had a way to speed up the recovery.
Yeah. It's a hard process for some people. For some people, it's so smooth, and they're just, they can bear with it. It's tricky.
I find the thicker the skin the patients have, it seems that those are the patients that are most frustrated with the healing process, because many of those patients are seeking out definition of the tip, which may be impossible to completely achieve. But again, we tell them we're going to do our best with what's under the skin to try to create some definition, and then we're relying on the skin to go through those phases of healing. And the last phase is when we're going to be able to really appreciate what changes were accomplished from the surgical process.
Well, let's talk about skin, since that was one of my questions a little further down. But the difference between thick skin and thin skin, does that require an open rhinoplasty if the skin is thick? Like, how do you get the most bang for your buck if you're doing a rhinoplasty with thicker skin?
Right. So the surgical approach, whether it's closed or open, really varies amongst different doctors. Some doctors are trained in one or the other. I happen to be trained in both, and like both for different indications. So closed rhinoplasty is when all the surgery is done from the inside. Open rhinoplasty.
No cut. Nothing on the outside.
There's cuts, but they're all internal cuts.
Yep.
External rhinoplasty or open rhinoplasty is a procedure that was popularized initially in Europe and then brought actually to North America by a surgeon, Dr. Goodman, who was the professor at the University of Toronto where I trained. So it sort of had a historical aspect linked to the University of Toronto. And that's an operation where an incision is made across the bottom of the nose. The skin and soft tissue is elevated off all the cartilage and bones. You can see very clearly. It's surgically has some advantages for visualization. And some surgeons, that's the only technique they ever learn. So that's what they use for every nose job. I like that technique for thicker skin patients because it allows me to sort of structure the nose and create a lot of as much change as possible to the underlying cartilage to set the stage for the nose to hopefully create some definition over time as you go through the healing process. So we're not just removing or thinning the skin. We do a little bit of that, but it's more what we're doing with the cartilage underneath it to try to create almost like a tent post to give some definition.
Can you thin the skin from underneath? Is that possible?
You can, but you have to be very careful because you can actually damage and cause some scarring in the skin if you're too aggressive with the thinning. So there's different layers of skin. The deepest layer above the cartilage is sort of a fibrofatty layer, and the fibrofatty layer, we can actually debulk a little bit of that with sharp instrumentation. So we do that more so. We can do it through closed or open, but with an open rhinoplasty, you probably have a better shot of doing that component of the operation than in closed rhinoplasty. That being said, there are some patients that we've done with closed rhinoplasty with thick skin who are thrilled with the results. The trouble for me is because I offer both, some patients, if they don't get the definition, then they second guess it and say, oh, maybe I should have had an open rhinoplasty.
Yeah, we've heard that.
Yeah, so we've heard that. So sometimes we sort of give patients, let them be involved in the process. If I think that I could accomplish the results through a closed approach, I'll tell them that. If I say I could do it open, I'll tell them that. If I say I could do it either, sometimes we have a back and forth conversation about which technique to use.
So for those of our listeners or viewers at home, they want to know, do I have thin skin, thick skin? How can I tell?
Usually most people know a little bit. I mean, if you look at someone's nose where they have thin skin, you can almost see the cartilage structures right underneath the skin. If you see someone with medium thickness skin, like you're probably not going to see quite all those same highlights of all the cartilaginous structures, specifically on the tip. And in thicker skin patients, you may see some textural changes to the skin, some ill-defined aspects. The details of the lower third of the nose may look just bulky.
Or it could look chunky.
Yeah.
Chunky, a little more square, a little more boxy.
You can see boxy
Yeah.
tip noses that are thin skinned too, though,
Yeah.
but you'll almost see the cartilage like right underneath that it's showing. It's more when it's amorphous, almost like you just don't see any definition. And then lastly, you can almost feel it. Sometimes you can lift the skin off the cartilage framework. So if you grab the tip of your nose and you're sort of stroking it like this, if the skin actually lifts off the cartilage, then you probably have thicker skin. If it feels like it's sort of stuck down to the cartilage, then you probably have thinner skin.
Okay, let's get back to some of the frequently asked questions that we get. Splints, do they shape the nose? We get patients calling the day after surgery, my splint, it looks crooked. Oh my goodness, is my nose going to heal crooked? It's not really shaping the nose, I don't believe. So maybe you want to elaborate on that.
Again, just like everything else, it depends on who you ask the question to. I think the vast majority of surgeons believe that the splint or the capsule is a protective aspect following the surgery. It's going to reduce the swelling by putting a little bit of gentle pressure on each side of the nose. When I trained, we put plaster Paris casts on everyone. Some surgeons use very large ones that went right up onto the forehead. That was largely for swelling. It wasn't going right up onto the forehead really for shaping of the nose. Also, similarly, we use nasal packing from the inside to reduce bleeding. So the conventions have shifted a lot to be more minimalistic, less intranasal packing, and smaller protective splints. If the splint's way off center, then obviously we tell patients to come in and we'll take a look, and sometimes we remove them and reposition them. More often than not, there's just a bit of swelling and it looks a little distorted. And again, they're not really there to shape the nose. They're really there. We're not squeezing them really tight. We just have them sitting on the surface to compress very gently some of the swelling out of the over the nasal bridge, just to reduce the swelling as they go through the healing process.
And what happens if they sneeze or they blow their nose? And we recommend in the post-care not to do that. So what's the reason behind that?
Well, it's not going to ruin the rhinoplasty result, but if you sneeze, you're actually exerting. First of all, it's an unconscious thing. You can't really control for it, but it's a lot of force going through the nose. So it's almost like the speed, I think, of a hurricane is the speed of the air going through the nose when you sneeze. But it could, first of all, just make a bit of a mess. You may have blood sort of splatter around the area. Second of all, it could initiate a bit of a nosebleed after rhinoplasty. But you can't really control for it other than we tell patients if they're going to sneeze, just keep your mouth open. So a lot of the force is sort of shared between the mouth and the nose, and sneeze into a napkin. But
I always say keep your mouth open and tickle the roof of your mouth. That's my advice to some patients.
That's your trick? Okay. Yeah. But it's not going to ruin anything. But again, don't blow super hard. If you're going to sneeze, keep your mouth open. And those are little tricks that may help.
Now, people often will say in the healing process, my nose looks asymmetrical. Even when the splint comes off, people can say that. And, swelling has a way of making things look a little wonky during the healing process. What can people do? How can they help deal with the swelling?
Well, there's two separate things. There's asymmetry and asymmetric swelling. So, if we operate on someone who's got a very asymmetric nose, sometimes even with best surgical intent, there may be some asymmetries even after the surgery. The goals of the operation are to make it as symmetric or improved as much as possible. And again, it's sometimes hard to really see the results for many, many months, especially on noses. The more complicated, the more time. So when we finish the operation, we evaluate the nose on the table. That's kind of the best sense of what we've achieved. There's obviously some intraoperative swelling, but that gives us the best sense. Then we've got to sort of put our faith in, the healing process. So then we're going to put on the splint. We're going to be going through the healing process, and we're in it together with our patients. We're going to be waiting it out over the next few months. 90% of the patients, it's sort of smooth sailing. Everything's great, and they're happy, and they're following the progress of improvement. The odd person, we have to go, with the flow and see what happens through the healing process. 1 in 10 patients that we operate on at the end of the year, we may have to go back and do some additional refinement or modification to try to enhance.
And that's an average. It doesn't matter who your surgeon is. That's just the nature of the surgery.
I think that's an average number. Yeah. I think that's a number that we commonly quote. I think different surgeons will quote different numbers. I had a surgeon I trained under who said they had almost a 0% touch-up rate, which I didn't think was accurate. But, he wouldn't know if he had a touch-up rate of 0% because patients may have gone to another surgeon for a touch-up.
Fair.
So,
yeah.
To say you have no touch-ups or rhinoplasty means you just don't want to do a touch-up. If you do a lot of noses, you're absolutely, I've been in this industry a long, long time, and I have close colleagues who do rhinoplasty. Both together, we have a cumulative experience of 50 years, and we share very common sort of senses of
realistic
touch-up rates and ways to manage sort of specific situations like that where we have to go back and do additional surgery to get to the best results possible. I think that's obviously we want it to be a one and done, but sometimes we have to do more than one to get us to the point that we're happy and the patient's happy.
Well, it's important that people understand that when you finish the surgery, you get it to as perfect as possible before that nose leaves the operating room. So what happens afterwards is your body's response to the trauma, to surgery, which is out of your control to a certain degree.
When I tell patients, I say there's a few components to the operation.
Yeah.
I'm only one of them. So there's your anatomy, there's your surgeon, and then there's whether you believe in God is the third component. Anyway, I think that's sort of, we've covered a lot. I think that's a good start. We probably can come back and do even more on rhinoplasty because there's so many things to talk about. I hope you got something out of it, and we'll see you back at the next podcast.